and thanks for taking the time, everyone, to spend the next 45 minutes or hour with us talking about the Heart and Vascular program. It is a gorgeous day outside. I would love it if we could actually sit around in a circle outside and actually be together, and maybe within the next few months we will be able to do that. But for now, we're still relegated to WebEx. So thanks for tuning in, and thanks for all the support you've provided to Baystate and Heart and Vascular to date. I recognize many of the names. Some I don't. Some are anonymous through call-in user ID numbers. So if you want to hide, that's a very good way to do it. But we're going to get started. Scott, can you start the slides? Or Kate? So we all know who I am at this point, so we can skip that. And we'll talk about heart disease, which still remains the #1 cause of mortality in the U.S. At one point during the peak of the pandemic, COVID exceeded heart disease, but that was only for 1 point. And as you can see, in 2020, there were approximately 690,000 deaths from heart disease. That was actually a 5% increase, and the first increase we've seen in over a decade. In comparison, there were basically half as many COVID-19 deaths. This is not to diminish the impact of any death, but heart disease remains a huge problem. And I suspect that some of this increase in heart disease deaths is attributable either directly or indirectly to COVID-19. This is a disease of men and women. As I grew up, and as many of you grew up, this was a disease of men, but it's an equal opportunity killer, it's an equal opportunity disabler, and women are as affected as men, perhaps a little later in life, but nonetheless they are affected at the same rate. That all having been said, there is a positive side to all of this. If you look back into the 1960s, the death rate per 100,000 due to heart disease was over 500 per 100,000 population. It has now been cut by almost 2/3, if not more, by the time of 2013, and that number is probably dated as well. And short of this uptick, I suspect it's even lower yet. When I started training, if you were in a heart attack study, for those of you who are in academic medicine, you well know, not all patients qualify to be in a study. The mortality rate in the MI studies at that time was around 15% in the control arm. It's currently less than 3% for all patients. So a huge impact on myocardial infarction mortality, although that has in fact spawned an epidemic of congestive heart failure, which we'll talk about a little bit more. Kate, if you could move to the next slide. Next slide, Kate. Here we go. Sorry for the delay. So we're really here not to talk about the epidemic of heart disease in the U.S. or worldwide, but rather to talk about the Baystate Heart and Vascular Program, something that you, in fact, have supported over a decade. And really, the fundamental of this is to really be a regionally integrated program. And when I say regional, I mean every region that Baystate Health touches: the north, the south of here into Connecticut, east of here towards Palmer, west of here out towards Noble, and I will even include the Berkshires in this, as we've had a strong, long-standing relationship with them. So I think this, when I was brought here, this really was set up to be the Davis Heart and Vascular Center. Really what we're talking about now is a regional program, and something that really has in fact taken off and has really expanded into that regional platform. From my perspective, the key is that regional platform being recognized at a national level, particularly with regards to safety and quality. I'm a firm believer in patient experience. We still have a little room to work there, but really safety and quality is something that really stands at the core of the Baystate Heart and Vascular Program, and is something that I can proudly say is recognized at a national level, which we'll talk about a little bit more. As I said, this has really been anchored by the Davis Heart and Vascular Center, which is located in the Mass Mutual Tower, thanks to the generosity of the Davis family. And when I was brought here, the goal was to create a multidisciplinary care platform whereby doctors of different disciplines went ahead and worked together around the patient to meet the patient's needs. And I'm happy to say that was the architecture by which the Davis Family Heart and Vascular Center was built upon, and it really has worked. I think we have one of the most integrated cardiovascular service lines or cardiovascular platforms in the country when it comes to cardiologists, vascular surgeons, cardiac surgeons, interventional radiologists, really all working side by side together to benefit the patients. And we've done this both in the hospital, and now we've done it on an ambulatory level as well. So it is a very comprehensive program. We pretty much provide everything there is in heart care short of heart transplantation. We could talk about that during the question and answer session if anyone has any questions about that, but that was a decision that was made a long time ago, again, for safety and quality reasons more than anything else. Hey, if you could turn to the next slide, that'd be helpful. Advance the slide, please. Okay. Here we go. So I've decided to give you some timelines and milestones. So prior to my arrival back in the 2000s, the institution decided to build this Heart and Vascular Center as part of the Hospital of the Future and the Hospital of the Future campaign. Many of you I know were involved with that then. Many of you remain involved now. I was recruited with the goal of working with Betty LaRue to help design and build that center. If you think back to 2008 and 2009, we had different challenges at that time. It was called the financial crisis, and you can go back, to the credit of the administration at that time, as well as the Board of Trustees, it was decided to proceed with the Davis Heart and Vascular Center despite the economic challenges. And I think that was actually a really, really, really insightful decision. It really moved things forward, right? So construction started shortly thereafter, and in early March of 2012, we opened the Davis Family Heart and Vascular Center, as well as the cardiovascular floors on M5, M6, and M7 as part of this expansion. That was the biggest milestone. A few months later, we performed the first commercial TAVR, or percutaneous aortic valve replacement, in Massachusetts. We could have done that a little earlier, but we decided we would wait to get into our new building, work out some of the kinks, and then move forward. Another milestone was the first ventricular assist device implant outside of Boston in Massachusetts. That was in October of 2016. For those of you who watch television and see billboards, that was Ernest Scruggs. He was the face of Baystate Health for a while, and he's still the face of Baystate for us. Another milestone, which I'd rather not talk about, is COVID-19 and the onset of the pandemic. We'll talk a little bit about that, as how it affects people's hearts, but also how it affected the heart and vascular program. And there we go, 13 months later, and we're now well into the beginning of construction for what's being called the Hospital of the Future expansion project. That's part of a larger master facility plan, but for heart and vascular, it really means the culmination of what we thought we would be building in 2009. There'll be the cardiac catheterization laboratories will be moved over to behind where the heart and vascular operating rooms are. The electrophysiology labs, which are on a different floor in the Daly building, will be moved as well. There will be a dedicated neurovascular lab, as well as a flex lab, and expanded prep and recovery bays for those of you who have toured the care unit, as well as some changes in the operating room configuration. So a lot going on. That project is expected to really get underway in June, July, and August with very significant construction, starting with some of those cath labs, and hopefully will be done in about 14 to 16 months, and we should be moving in there. This all speaks to where we've been and where we're going, but I'd like to sort of review some of what heart and vascular is about. I alluded to national recognition, and we're going to talk about that when Kate advances the next slide, please. So I've been through this brag slide with many of you before. I just keep adjusting it because the honors continue to accrue. We were once again nominated as a Truven IBM Watson Top 50 Heart Hospital teaching hospital, which is the most coveted position this year, and that's 9 out of 11 years. U.S. News and World Report has recognized us. The Society of Thoracic Surgery has recognized us. We remain the highest volume angioplasty center in the state of Massachusetts, and we have top 10% outcomes for angioplasty, TAVR, and acute MIs at a national level when we look at our registries. People from Yale and Stanford and elsewhere have come to see how it is what we do, looking for the quote-unquote secret sauce, as somebody from Yale put it, and we continue to attract NIH research funding on the part of some of our investigators. So really a lot done over the last decade or so, and something which we really are counting on continuing as sort of the crown jewel of the organization. Next slide, please, Kate. We are a high volume program, as I alluded to. We're doing about 700 to 800 cardiac surgeries a year. Some of those have gone down as a result of COVID. We're still doing about 1,400 coronary angioplasties or stents a year, 80 or more aortic aneurysm repairs percutaneously, about 250 TAVRs, which again makes us a very high volume program. We were doing about 350 ST elevation MIs a year. We're now up to somewhere between 425 and 450 in what is truly a regional program. We are the only provider of this life-saving primary angioplasty care in Western Massachusetts. It is highly coordinated, it is highly effective, and it is highly recognized. And we do well over 42,000 ambulatory visits in the Baystate medical practices alone, as well as more visits in some of the affiliated cardiology practices. What this really translates into is world-class, nationally recognized care, and it's for the people of Western Massachusetts right here, locally available to all of us. Next slide, Kate. Well, how do you do that? It's not me. You have great facilities, and that facilitates great talent. I'm referring to physicians, advanced practitioners, nurses, and I will say we have some of the top cardiovascular administrators around. We have been able to draw practitioners from very, very, very well recognized programs across the country. You see the list there. I don't need to read it for you. This is not by accident. Physicians from these programs train in cutting edge programs, and they want to practice in cutting edge programs. And the facilities and the talent that is already here is the biggest draw as I go out and try to recruit new talent. And that talent, even more so than the facilities, is the backbone of the accomplishments that we just talked about. We have really, really, really great practitioners and nurses, as well as really cutting edge facilities. So many of you have heard this before. The song remains the same, as they say, but these are really fundamental issues in building and then maintaining a top heart program. Now maybe it's time to sort of go through some updates about what's gone on since we last spoke, which was back in July of last year when we were all sort of reeling from the pandemic. You want to advance the slides? Next slide, Kate. So I couldn't do this talk without at least reviewing what the COVID-19 pandemic has meant to us. I think many of you have heard about it from a lot of different perspectives, but I'm going to very briefly review things. As I said, the pandemic started here in Western Massachusetts and basically in the Northeast in March of 2020. And our elective and really pretty much all heart and vascular services except for share emergencies were truly interrupted from March until June of 2020. We literally moved out of the Mass Mutual Tower and moved our patient care sites pretty much into other buildings, including the Chestnut Ambulatory Care Center for our ICU, and we moved back to the old daily operating rooms. Happily, I think we've seen limited cardiovascular complications of COVID here in Western Massachusetts, but we have seen some, and we'll talk about that a little bit. During this time, the vascular surgery and heart attack volume remained fairly constant. That was not the case nationally. In New York and other large areas, the number of heart attacks went down dramatically. I don't believe that the number of heart attacks went down. It was the number of people going to the hospital that went down, and that in part probably attributed to some of that increase in cardiovascular death over the last year. Happily, we did experience that. We did see people delay care, and so some of those heart attacks, some of the vascular surgery was in a much more advanced state, and that was very unfortunate. We sort of bounced back from that. However, we had some staff illnesses in heart and vascular in July, as you may recall. And then in November and December, we had a large number of nurses primarily who went out sick with COVID. And this, in fact, did limit some of our care. It's very difficult to just come up with nurses who can take care of cardiac surgery patients as they come out of the operating room. And so to some degree, it did limit care for about a month or so. As we look at the second surge, certainly which started in November and December, and I say November up really through the current time because we're still impacted by this, it has limited the number of beds we've had. We've had a temporary loss of our prep and recovery areas and a temporary loss of a cardiac step-down unit. So COVID has, in fact, impacted the heart and vascular program as it has impacted everyone. Notably, the request/demand for our services has not decreased, and so the work carries on, but I did feel it's important to review where we've been over the last 14 months. The fact that we've been able to keep up with this request and demand is really testimony to the support of the institution, but it's really, really testimony to the resilience and strength and commitment of our nurses, our PCTs, as well as our providers. So I want to take an opportunity to thank them. It would also be difficult to advance the next slide, please, Kate, to do a talk about heart and vascular in 2021 without at least touching upon the impact of COVID-19 on the cardiovascular system. Happily, I believe most of this is in our rearview mirror, although I don't think we're completely out of the woods. But hopefully we won't be doing another talk about the impact of COVID-19 on the heart when we meet in 2022. So as many of you who have sat through my talks before, I tend to simplify things. The heart is really just a pump. It's got a timing conduction system, which is that EKG pattern you see up at the top. Like any pump, it requires fuel. Those are the coronary arteries that you see outlined on the front of the heart. It's got pumping chambers, which are the ventricles and atria. It's a 4-chambered pump. And it's got valves keeping blood flowing in the right direction as those ventricles and atria pump. So this is the substrate on which COVID-19 then has its impact. If you can advance a slide, Kate, that'd be helpful. I'm not going to spend a lot of time on this. I went through this in a talk back in February. I believe that's been recorded, and if you're really interested in it, you're welcome to go back and find it. But first part of this is that the COVID-19 virus can actually directly infect the organs of the cardiovascular system, including the heart. We call that myocarditis, and the blood vessels, which is vasculitis. That's comparatively small relative to the other problems that are caused in a more general sense because of the inflammation state that's caused by the infection. There's something called cytokine storm. This is how 30 and 40-year-olds who are otherwise really quite healthy end up remarkably sick. There are clotting disorders that are associated with this, and there's probably a tendency for blood vessels which have atherosclerotic plaque in them to rupture. So all of this is linked to the inflammation due to the infection. So what does this mean for the heart? Well, it can impact the pumping chambers of the heart, ventricular function, which we would call congestive heart failure or cardiomyopathy. That can happen from the cytokine storm. It can happen from direct infection. As I said, the blood vessels are affected, arteries and veins, either with inflammation or with an increase in clotting tendencies. The timing mechanism that we talked about with the heart, there have been arrhythmias associated with this, including atrial fibrillation, but also ventricular, more lethal ventricular arrhythmias. And then I would be remiss to say that the deferral of care by our patients, their reluctance to come to the clinic, their reluctance to come to the hospital, and thereby putting off preventive measures and surgeries and procedures is a secondary impact. And then many of you have heard about long hauler syndrome. Some patients seem to be afflicted with sequelae of the virus for quite some time. From a cardiovascular perspective, probably the biggest one of that is called postural orthostatic tachycardia syndrome, or POTS, which is a dysautonomic function. Happy to talk about any of that in the questions and answers. Next slide, please. I would also be remiss if I didn't talk about the COVID-19 vaccine. I suspect that many or most of you, in fact, have received the COVID-19 vaccine, but this gives me a little bully pulpit by which to preach about the need for the vaccine. So they are safe for heart patients. Patients in the 65 plus group have been well represented in the clinical trials, which is in part why they were the first to get the vaccine, as well as their increased risk. No signal of risk in that population. As we stated, COVID risk is especially high in our patients. The vaccine's been endorsed by the appropriate societies, and the vaccines are highly, highly effective, at least 95% for the mRNA vaccines. So if you haven't been vaccinated, and I'm not going to get into the politics of that, if you're not going to do it for yourself, then do it for your family, your friends, and your community. And I'm going to sort of stop around that. So I think that pretty much will wrap up our COVID discussion, but I want to talk about what we've done outside of COVID as well. So if you can advance the slide, Kate. We'll touch a little bit upon cardiac surgery. There have been some changes over the last 3 to 4 years in our cardiac surgeons, retirements, and the like. I'm happy to say we've got a very integrated, collaborative group of 5 cardiac surgeons who really are doing a great job, and I expect to continue to see great things out of them under the direction of Dr. Schwann. The left ventricular assist device program has continued to expand even with COVID. We're due to be accredited by the Joint Commission shortly, and I'm happy to report that the 22nd left ventricular assist device went in at Baystate just yesterday. I don't know that we've talked about ECMO before. ECMO is basically heart-lung bypass that's done on very sick patients, cardiac patients, but also COVID patients. We're up over a rate of over 60 this year. It probably puts us in at the number 2 position for the state. We've used it extensively in COVID, and we'll talk a little bit about that more. But that program is expanding and is being highly organized. We've gotten a lot of support from nursing in that, and they are to be commended. I think we've advanced very well in what we call advanced cardiac imaging. Radiology has gotten new CT scanners that are performing at a completely different level than what we had in the past, and this really goes a long ways towards allowing us to image the heart in a less invasive way. Well, we can actually do coronary angiograms with this technology, and it's very important for the valve work we do. We're also due to get new MRI scanners very soon. You'll see construction along Medical Center and Drive if you look back to where the old emergency room was, and this is a emerging technology that we really need in order to keep up with the management of our patients with myocarditis and congestive heart failure. And as I've spoken, the Hospital of the Future build-out is already underway. So I would say these are the updates for the year. I'm hoping and happy to talk about any of that. Next slide. So we do this not for the program, but we really do this for our patients. And the next one is really a very impactful story. And we're going to talk about a 39-year-old gentleman. He and his wife had been attempting to get pregnant for about 8 years through IVF and other advanced technologies, fertility planning. And they got pregnant, and they were about to come to understand the gender of the baby, or what I now understand is now called a gender reveal. It wasn't in my time. And the wife looked out, and the poor gentleman was slumped over his lawnmower as he had been mowing his lawn. He had suffered a cardiac arrest. They did CPR. They called 911. The patient was effectively resuscitated, and he was brought to Baystate Medical Center. Here, it was apparent he was having some type of heart attack. One of our very talented interventional cardiologists, Evan Lau, took him to the cardiac catheterization laboratory, where he, in fact, had a lot of blocked arteries, really too many blocked arteries for a man of just 39. And he fixed those arteries. Again, a very talented individual, and put in a support device called an Impella. That kept our friend going for about 24 hours, and then he, in fact, deteriorated. At that time, the cardiac surgery was called. Dr. Kelly Wanamaker, one of our new cardiac surgeons who we recruited from the Brigham, she's really a spectacular individual, went ahead and instituted what we just talked about, ECMO. That supported him and allowed his heart to recover. And I'm happy to say that about a week ago, we first were able to get the ECMO out, and he was left on the Impella support device, and then I was taking care of him at that time. And subsequently, a day or two later, we were able to get the Impella out. I just saw him down in the coronary care unit. He still has some challenges ahead of him, but he, in fact, is what we would refer to as a miraculous situation, a miraculous save, and I look forward to him being able to leave the hospital and actually doing his gender reveal party with his wife. So this is Heart and Vascular at Baystate. This is what we do, and people like this 39-year-old is exactly the reasons why we do it. Next slide. So that's where we've been. Where are we going? From my perspective, it's to continue to advance the program, to continue nationally recognized world-class care. We've shared some of this before, but I think it's been better defined and presented to senior administration, but we really want to continue to move forward on what we consider an advanced heart valve program. We look forward to training Dr. Wanamaker in the most advanced valvular surgical and percutaneous techniques. And COVID sort of put an interruption on this, but we plan on moving forward. We're also very interested in expanding our treatment of aortic disease. Aorta is the largest vessel in the body, and while there's been miraculous advancement, things are moving very, very rapidly in this field. There are new stent grafts that have begun to evolve, some of which we don't have yet, but we intend to get, whereby the physician using 3D technology modifies these grafts and prevents the need for surgery. We also just saw a demonstration of a completely new approach to imaging that basically uses the equivalent of CT scans and GPS combined to create imaging inside the body and treatment inside the body that is completely radiation free. So we're looking into that, and hopefully next year I'll be able to show you some pictures of that. Congestive heart failure, as I said before, continues to represent a huge problem, in part because we've been so successful with our treatment of acute myocardial infarctions, and we intend to continue to advance those therapies with things like LVAD, but also come up with better ways to manage the large population of heart failure patients out in the community, something we would call population health. So we're advancing at the cutting edge technology side, but we're also advancing on the day-to-day care side. A lot of interest in arrhythmia and atrial fibrillation treatment, a lot going on there. This is going to be a growing area. There are going to be new technologies, and we intend to be in the thick of it. And then ultimately, when we've relocated the cath labs and the EP labs to the HOF, we hope to move the non-invasive cardiology group, or ECHO group, to the HOF. So that's the plan. What's the strategy? Kate, can you advance the slide? So I'm pretty fundamental. I think the key on this is to attract and retain the best and brightest practitioners and then allow them to introduce emerging technologies and therapies. And this is going to require the following: continued recruitment, physician and staff education and development. Examples of this include training our cardiac surgeons and vascular surgeons in new valve and aortic programs, training our nurses in how to take care of those patients and patients on ECMO, new technologies. The idea of imaging the vascular system without radiation is really remarkable to me. I stood in lead for decades and was exposed to radiation, and anything that can be done that the next generation of vascular and cardiac practitioners can avoid that, I think is wonderful. And then we continue to need to support our programs. This stuff doesn't just happen. It requires a lot of clinical support staff, and it requires a lot of non-clinical support staff. So that's been about 25 minutes of the Heart and Vascular program. Next slide, Kate. And really, this is an opportunity now for you all to reflect on what I said and ask me questions, and I'll do the best I can to answer those. Scott?
Dr. Kugelmass, thank you very much. A fantastic job. You certainly cover a lot of territory in the presentation, so thank you very much. I do want to encourage everybody who's participating today. There's a chat function on your screen if you're on WebEx. You can type your questions in the chat function. We've received several questions. And Dr. Kugelmass, forgive me if you've already covered this. I'm trying to make sure we answer them as best we can. So you might have covered some of this material.
I might have covered it, but I might not have covered it well, Scott. So if there are questions, that's actually a good thing. And I covered a lot of material in a very short period of time. So I really look forward to making this very, very interactive.
Okay, first question, Dr. Kugelmass, have you seen any COVID-related heart issues?
I'm happy to say I haven't seen any for me, but all joking aside, yes, we have seen COVID-related heart issues. We've seen patients who have the long hauler syndrome, patients who experience dizziness, tachycardia, or rapid heart rate. We've seen some patients who we believe had either direct or indirect impacts on their ventricular function or congestive heart failure as a result of COVID-19 infection. And I can't help but believe that some of the heart attacks we saw and vascular issues that we saw, including what we call pulmonary emboli, weren't in fact related to COVID-19 infection. So yes, we've seen it. I'm happy to say maybe I'm seeing a little less of it now as we're working our way through the end of the third surge, but it's still out there.
Okay, thank you. Next question comes from somebody who identifies themselves to be around 60, so 60 years old. How does my family history affect heart health? My mom and dad both have AFib, and my mom has some other electrical issues that require a pacemaker. Should I be seeing a cardiologist regularly, even if I don't have symptoms?
I think the first person to see is your PCP or internist. There certainly are genetic or family predispositions to certain types of arrhythmias. I can't say that that is the cause of what's going on here. I think they would be the first one to tease out whether they thought you should actually see a cardiologist. If you came to see me, I would sort of assess what in fact is going on, confirm you're not in atrial fibrillation, maybe do some other assessments of things that we know predispose to atrial fibrillation. Sleep apnea is one of those. High blood pressure is another. There's some others. And so, we are who we are from a genetic perspective. We can't change that, but we can, in fact, change some of the things that predispose to various types of heart disease, whether it's arrhythmias or coronary disease or other things. So if you were to see a cardiologist, I would probably go ahead and identify what I thought your risk factors for atrial fibrillation were, but I'm not sure I'd start with a cardiologist. I would probably start with your internist or primary care physician.
Thank you very much. Another question just came through. What is Impella?
Yeah, well, sorry I didn't explain that in greater detail. It's actually really, really cool. It is a rotary pump. The intake portion of it sits inside the left ventricle or the pumping chamber, and the exit port sits in the aorta or the major artery. And we are able to pump anywhere between 2.5 liters and 5 liters of blood per minute using this temporary pump. Think of it as an LVAD that's very short term, and it works in a slightly different way, but it's basically the same concept. They're put in and they have different powers. Some are 2.5 liters per minute, some are 3.5 liters per minute, and some are up to 5.0 liters per minute. The average pumping for a human heart is around 5 liters per minute. So we use these to support people when their hearts are not working, such as in the patient story I gave today. We also use it for ECMO for reasons that I think are pretty detailed, but it helps unload the heart and keep blood from backing up inside the heart, which is a secondary problem with ECMO per se. I'm happy to go into more detail with this. I will say that Impella is made out of a company in Danvers, so it's a locally developed and sourced product, so to speak, in addition to being a real lifesaver.
Thank you very much. Next question, are there DNA tests that can detect your propensity for heart issues?
There are across a broad spectrum, from an incapacity to metabolize cholesterol appropriately to certain types of what we would call cardiomyopathies, IHSS or obstructive cardiomyopathy, the Pete Maravich syndrome, for those of us old enough to remember Pete Maravich. Um, it can be detected in many cases, not all cases, but in many cases genetically. Certain diseases of the vasculature can be detected genetically. Certain types of arrhythmias can be detected genetically. And I think what you're going to see over time is as we better identify this, we'll be able to identify, one, who's at risk, but two, we can potentially target therapies for those at risk if there's a particular genetic defect.
Thank you. Trying to put these questions where they kind of play off each other a little bit. So another one that came in was, what are some things people can do to stay heart healthy?
Well, I think we alluded to them. If you have sleep apnea, get that treated. If you're overweight, lose weight. If you're inactive, get active. If you smoke, that's a good one to give up. A well-balanced Mediterranean diet, so to speak, is a much better approach than a heavy fat, saturated fat, carbohydrate-based diet. As I said, inactivity, ethanol should be, if it's going to be consumed at all, should be consumed in moderation. Those are the basics. And if you have some genetic predisposition to something in your family, then probably having that evaluated sooner rather than later, if that's possible, would be another good thing to do.
Thank you. We talked a lot about the facilities here. You did at the Baystate Medical Center. One of the questions, are heart and vascular providers spending any time seeing patients at the community hospitals or locally? So outside of BMC?
I got a sort of an echo on that, Scott. Can you
Sure, no problem.
repeat it?
We talked about the Davis family, the Heart and Vascular Center at BMC. One of the questions was, are any of the heart and vascular providers spending any time seeing patients at the community hospitals or locally?
Absolutely. We are seeing patients in 4 counties, even though we only represent 3 counties, Hamden, Hampshire, and Franklin. We actually are sending a cardiac surgeon to the Berkshires as well to see patients there. We see patients in all of the hospitals. We take care of patients with cardiovascular issues in all of the hospitals. We have ambulatory offices in Wing, in Palmer. We have ambulatory offices at Noble in Westfield, and we have ambulatory offices at Franklin Medical Center in Greenfield. But in addition to that, we have offices where we see people on an ambulatory basis in Springfield, North Main Street. We see people on High Street. We see people in Longmeadow. We see people in Northampton, and I'm sure I'm leaving somebody or some region out. But we have to. The real point is that we see people all over. It really is a regional program. The anchor is the Davis Family Heart and Vascular Center, and I don't want to diminish that in any way, shape, or form, but we see people everywhere. And if you think about it, even with heart disease, the vast majority of your experience with heart disease is managed in an outpatient ambulatory center. It's not managed in the hospital. So it's all that activity outside of the Davis Heart and Vascular Center is really where the majority of this activity goes on. Hopefully that helps answer the question.
That was great. Thank you very much. Another question just came through. Can you briefly describe cardiac care for babies and children at Baystate?
I can describe it. I'm not responsible for it, but I have some sense of what goes on. So there is a division of pediatric cardiology. Pediatric cardiology is a separate subspecialty. You basically go into it from pediatrics residency. We have pediatric cardiologists. We share some technologies like echo and EKGs with them, but they mostly manage the babies and children themselves. What has evolved over our lifetime is that babies who are born with what we call congenital heart defects, often holes in their heart or plumbing that is not plumbed in the proper direction, they started getting operations for this in the late 1950s, 1960s, and this really advanced through the 70s and now up to now. Some of it's even done in utero at this point in time. But those patients are surviving. These are patients who never would have survived either the first year or the first decade of their lives. They're surviving. And so there's actually, as we refer to babies, there's a whole subdiscipline and subspecialty of cardiology known as adult congenital heart disease. It's a separate board exam. And we've teamed up with a group from the Brigham as well as Children's Hospital, and we offer adult congenital heart disease services in Springfield at 3,300 to the population in Western Massachusetts. This is a group that often sort of quote unquote falls off the radar screen after as they become adults, but it's important that they be followed closely because sometimes there are secondary changes that happen in the heart after it's been repaired when they're children. So there is a pediatric cardiology program at Baystate. It's not particularly, they don't have a cath lab or do surgery here. That's typically linked to Boston. But for those who did have surgery and procedures, we continue to see them as adults.
Thank you. Another question, and obviously COVID is still, on a lot of people's minds, and you've certainly covered this, but maybe another sentence or two. How has heart and vascular care had to adapt and change due to COVID-19?
I think we rock and rolled with it, so to speak. We had to move. We had to learn how to operate in operating rooms that we hadn't operated in a long time. We've changed facilities. We've learned to adapt as nurses and other providers are impacted. We have shared our ICU with the surgical ICU for a long time. Beds that were typically used for what we would call step down or PCU no longer exist. So we've learned how to keep people in the ICU longer and then get them to the floor sooner. Those are sort of the most granular approaches, I think. We've had to learn how to take care of our patients by phone and televideo. For a long time we weren't doing that. Our patients, the feedback I've gotten is most of them don't really like it. It's not as personal. They like to see their doctors. So we've had to learn how to do that, and happily I can say we're moving back to the old system. But we learned some things along the way. Not everybody has to drive an hour and a half to come into Springfield to be seen when we've learned how to do televideo. We've learned how to screen patients in emergent situations like heart attacks and other emergencies. And we've learned how to take care of some of these impacts of COVID-19 on the heart and the vascular system itself. So a lot of it had to do with we had to relearn how we did our business and where we did our business. But some of it actually had to do with the medical impacts of COVID-19 as well. I'm not sure if that's what people were looking for in the question. I'm happy to expand upon that or work with the question further.
Sure. No, I think that's fine. Another question just came through. It's two parts. Can you please go into more detail about new imaging techniques and how is it different from the older techniques?
All right, so we'll start with something as basic as what we call coronary angiography, or what I did for a long portion of my career, where we actually engage a catheter. We go through arteries, we go up to the heart, we engage a catheter, put it at the origin of the artery that feeds the heart, and inject X-ray dye. It is an invasive procedure. We do a lot of it, but it is an invasive procedure and it carries some risk, not the risks it used to carry in the 1950s and 60s, right? A lot of that, at least the screening version of that, can now be done with a CAT scanner, all right? The heartbeat, like things that move. So you have to actually come up with software systems to gate or freeze the heart for each beat, and then using very sophisticated computer software that I certainly don't understand, recreate the vessel from a 3D model, okay? So we can do a heart cath with a CAT scan at this point. Now, if there's something there, we still have to do the heart catheterization. If we're going to do an angioplasty, we have to do that. Now, what's different, we've been doing those here, but the resolution has not been what it is now. The number of people we can do has not been what it is now. If there was calcium in the arteries, which is a different discussion, that was a problem. It no longer is now. So that's an example of newer technologies that have evolved over time. that allow us to do things that we used to have to do invasively that now we can actually do non-invasively. Likewise, cardiac MRI has made huge strides. We can actually detect certain conditions that could only be detected by putting catheters in people and measuring blood pressures. Now we can actually see it on a cardiac MRI. We can detect infiltrative diseases, or diseases that deposit material inside the heart, as well as other diseases that have to do with the scarring of the heart and predispose to other problems. That can all be done with cardiac MRI. That used to require us actually going in and getting muscle tissue from the heart, which is, again, a very invasive approach and something that's really quite dangerous in somebody who hasn't had a heart transplant. So this is just some of what we can do with these more advanced cardiac imaging platforms. And you're only going to see more of it, not less of it.
Great. Thank you. This might kind of play into the next question. A couple more questions for you. In your presentation, a couple times you talked about great facilities attract great practitioners and the importance. So how will the expansion of the Hospital of the Future build out impact this further?
Well, I mean, don't get me wrong. I like the cath labs in the Daly building, but they were built a number of years ago. It's not the first place I take people on the tour to show them cutting edge facilities, although I do take them there because, in fact, it's the busiest cath lab in the state. But this will give us larger rooms, which will allow us to do more procedures of different types, allow us to store our equipment appropriately. It'll allow for better efficiency and a better patient experience in terms of where patients come into the organization and where they're discharged from. And I think anytime you take somebody through the Davis Heart and Vascular Center, their eyes light up. And it's over a decade old now, or it's pushing a decade. I mean, at the time, it was the cutting edge facility in the country because everybody else stopped building in 2009. But 10 years later, it's still pretty darn impressive. And this is how we attract top talent.
Great. And I'm gonna leave you with a last question, Dr. Kugelmass. And so many people on this call obviously are supportive of everything that you do and we do at Baystate. How does philanthropic funding, what does philanthropic funding mean to the Heart and Vascular Department?
I think it means a number of different things. It's funding we can use to help train people. It's funding we can use to help educate people. It's funding that we can use to help support research initiatives. We didn't talk about that so much today, but top talent likes to participate in cardiovascular research, and that often requires some level of support. So those are the really obvious ones. It can help support programmatic development. And at a certain level, and I'll leave this to you guys in the foundation, it can help support the actual facilities or the purchasing of equipment. And we've used certain philanthropic dollars to purchase heart-lung machines, for example, sort of the big cocktail party approach. But there's a secondary approach, and I actually think it goes a long way to supporting the esprit de corps of the group, the team. So when someone's told that somebody made a donation because of the care that they received by Dr. X, or a donation is made to reflect the nursing care they received in a unit, or a donation is made to reflect the interaction they had in an office visit, we broadcast that information. We celebrate those. And so beyond what it buys is really what it reinforces. It really goes to support the team that provides this world-class care. You can build whatever building you want, and you can buy whatever machine you want. Without the team, you're left with a building or you're left with a machine. So, it buys stuff, and don't get me wrong, buying stuff is important, but it really serves as a major morale booster and engagement activity or effector for the cardiovascular team. People like to be recognized for what they do, and this is one way it's done.
Thank you very much. Yeah, just to play on what you said for our participants today, we call those gifts of gratitude. So a lot of times to recognize the care or to recognize somebody who made a difference in your care at Baystate Health, you can make a gift of gratitude, and it doesn't go to the person, it goes to the department of funding, but the person's recognized. And as Dr. Kugelmass said, that means the world. So I want to say, we're going to end the Q&A right now. I want to thank everyone for participating today, for your questions, and most importantly, for your continued commitment to Baystate and to the Heart and Vascular program. A very big thank you to Dr. Kugelmass. You're an incredibly great presenter. You do a wonderful job. The information is phenomenal. I want to thank from the Baystate Health Foundation team, Teresa Grove and Kathy Bronner and Kate Roberts, and the person behind the scene that does a lot of work for us too is Andrew Pond, just making these virtual activities come to life. For all of our folks that are participating today, again, thank you for your support. All gifts mean the world, whether it's for current use or to an endowed fund for the future. Just thank you for all you do. We hope you found today informative. And if you have any questions, please feel welcome to reach out to Dr. Kugelmass or the foundation anytime. So please enjoy the beautiful weather, and we look forward to connecting with you again soon. Thanks, Dr. Kugelmass.
I want to thank you, Scott, and your entire team. And I'm recognizing a lot of names on this list, not all of them, and not the numbers, but I want to thank everybody who participated for your time. There are a lot of other places you could have been on this beautiful day. So I appreciate your gift of time as well as the other gifts you make to the foundation. I look forward to doing this again. And again, as Scott pointed out, if you have questions, forward them to the foundation, and I'll try to answer them as best I can. Thanks a lot, everyone.
Thank you, everyone. Have a great day.